Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO!
Welcome back, everyone. Today, we're going to be talking about vulvar cancer, specifically early-stage vulvar cancer. Sydney, what are our learning objectives for today?
Our learning objectives are to describe the epidemiology of vulvar cancer, to discuss prognostic markers for vulvar cancer, to review the staging, to explore treatment for early-stage vulvar cancer, to acknowledge the data on lymph node evaluation, and to recognize factors which influence decision to administer adjuvant therapy for early-stage vulvar cancer.
Let's get started. In the United States, vulvar cancer is one of the least common gynecologic malignancies, with about 7,000 new cases in 2024, accounting for only 0.3% of all cancers. Of this small number, the vast majority are squamous cell carcinoma. Less common vulvar cancers include melanoma, basal cell carcinoma, Bartholin gland adenocarcinoma, sarcoma, and invasive Paget disease. The 5-year overall survival for vulvar cancer is about 70%. 60% of all new cases are localized at the time of diagnosis, 27% have regional spread, and 14% have distant spread or unknown stage. The median age at diagnosis is 69, with less than 20% of cases being diagnosed at an age younger than 55. The incidence of vulvar cancer has been increasing over the last few decades, but the overall survival has remained largely unchanged.
Squamous cell carcinoma can be preceded by an HPV infection leading to dysplasia, or by inflammatory conditions of the vulva, such as lichen sclerosus, leading to differentiated vulvar intraepithelial neoplasia. Similarly to HPV-independent squamous cell carcinoma of the cervix, HPV-independent vulvar squamous cell carcinomas tend to have a poorer prognosis compared to HPV-associated disease. In HPV-dependent disease, P16 staining is typically strong and diffuse, and P53 typically stains in a wild-type and heterogeneous pattern. Within HPV-independent disease, there are two staining subtypes: those with wild-type P53 staining and those with P53 mutations. The P53 mutated tumors are usually P16 negative and have the worst clinical outcomes of the three subtypes of SCC. Today, we won't review VIN or its treatment in detail, but there are excellent existing resources which our listeners can reference. Maya, if a patient is suspected to have vulvar cancer, what elements are needed in the workup?
Arguably, the most important step is the clinical exam. The lesion should be measured and biopsied. It's imperative to clearly document where the biopsies are taken from. You'll understand why soon. Blood counts, LFTs, and renal function should be assessed. HPV testing can be considered, but will also be stained for in pathology, as previously described. We should also consider HIV testing. As for all HPV-related cancer, patients should be counseled on smoking cessation. It's the only modifiable risk factor that can improve their chance of clearing their disease. Whether you need imaging depends on the extent of the disease. Per the NCCN, one should consider chest imaging with a chest X-ray and a CT chest if the chest X-ray is abnormal. A pelvic MRI is also reasonable to aid in surgical and/or radiation planning. If the tumor is stage 2 or above, or metastasis is suspected, a PET CT or a full CT imaging with chest, abdomen, and pelvis can be considered.
Staging for vulvar cancer was updated in 2021. There is a less complex stage 3 breakdown, and now upper 2/3 vaginal involvement, bladder involvement, and anal involvement are classified as stage 3 instead of stage 4. This emphasizes that local disease is often salvageable, whereas groin involvement portends a much worse outcome. In addition, the way that depth of invasion is measured has changed. Previously, the most superficial dermal papilla to the deepest point of invasion was used for measurement. Now depth of invasion is measured from the basement membrane of the deepest adjacent dysplastic or non-invasive REIT ridge to the deepest point of invasion. Pathologists are recommended by the NCCN to describe their methodology for measuring depth of invasion. It's important that we, as gyne-oncologists, ensure that this is being measured in the updated manner because it could upgrade staging and lead to overtreatment. Maya, as we mentioned earlier that HPV-dependent or independent status affects prognosis, are there other factors?
Yes, similar to other disease types, survival is stage dependent. 5-year relative survival is 86% for localized disease, 47% for regional disease, and 22% for distant disease. Outside of stage, the most important prognostic factor for survival is lymph node status. If the lymph nodes are negative, the 5-year survival is 80%. From there, the survival statistics are dependent on the number of involved nodes. For 1 positive node, it's 60%, 2 positive, 30%, 3 positive, 20%, 4 positive, 10%, and so on. So Sydney, does everyone need a lymph node evaluation? And how do we determine the surgical plan by stage of disease?
Great questions. The extent of surgical resection, approach, and whether to include nodal evaluation has undergone many changes over time and is dependent on stage. Historically, radical vulvectomy was radical. This involved a large butterfly incision with bilateral inguinofemoral lymphadenectomy, which was quite a morbid procedure. As time has progressed, the degree of dissection has lessened overall, now with sentinel lymph node biopsy in select cases. Early stage disease is defined as stage 1 and select stage 2 disease, where disease is resectable without removing the proximal urethra, bladder, or anus. In stage 1A disease, with less than or equal to 1 millimeter invasion on biopsy, a simple partial vulvectomy can be performed. If the resection margins are negative, observation is recommended. If margins are positive, re-excision should be performed. If these margins are negative, then observation or adjuvant EBRT are reasonable. If the margins of the re-excision are positive, then adjuvant EBRT should be given.
The surgical approach for stage 1B and select stage 2 disease is dependent on the location of the primary lesion. If there's a lateral lesion, more than or equal to 2 centimeters from the midline, a radical partial vulvectomy and ipsilateral inguinofemoral lymph node evaluation is recommended. At this time, sentinel lymph node biopsy or lymph node dissection are both listed as options in the NCCN, with sentinel lymph node biopsy only considered if the tumor size is less than 4 centimeters. If the lesion is central, then a radical partial vulvectomy and bilateral inguinofemoral lymph node evaluation is recommended. As you may have gleaned, if patients have greater than or equal to stage 1B disease, then a lymph node assessment should be performed as the risk of lymph node metastasis is more than 8% in these patients.
Okay. So how did we get to these recommendations? Can you tell us about some of the trials?
Sure. A lot of these are historic, but they do paint the picture of why and how we manage patients the way we do today. GOG 36 was published in 1987 by Sedlis et al., evaluating the predictors of lymph node metastases in superficial vulvar cancer. Data was reanalyzed and published in 1993 by Holmesley et al., with the same goal in the overall cohort, including superficial and deep disease. From 1977 to 1984, 558 patients with primary vulvar squamous cell carcinoma were enrolled and treated by radical vulvectomy and bilateral groin node dissection. 272 had superficial, defined as less than or equal to 5 millimeters invasion disease. Of those, 21% had positive groin lymph nodes and 10% had 2 or more positive lymph nodes. A logistic model showed that tumor thickness, grade, capillary-like space involvement, clitoral and perineal location, and clinically suspicious lymph nodes were significant predictors of groin node involvement. These weren't entirely reliable when used alone, but they were useful when combined into a statistical model. As stated, the overall cohort was then reanalyzed in 1993. They found that lymph node involvement was 19% in lesions measuring 2 or less centimeters, and 42% if they measured more than 2 centimeters. 24% of all patients with clinically unsuspicious nodes had surgically positive nodes. In the overall cohort, independent risk factors were identified. In order of importance, these included higher grade, suspicious fixed or ulcerated nodes, LVSI, older age, and depth of invasion. If the tumor was 1 millimeter, there was only a 2.6% rate of lymph node positivity.
GOG 74 was published in 1992. This study included patients with clinical stage 1 disease, tumors less than or equal to 2 centimeters, unsuspicious nodes, and depth of invasion less than or equal to 5 millimeters. They underwent modified radical hemivulvectomy and superficial inguinal lymphadenectomy compared to the standard aggressive en bloc radical resection. 155 patients were enrolled and 121 had follow-up. 19 of the 121 patients recurred, and 8 of 10 vulvar recurrences were salvaged by further surgery. Unfortunately, 7 of the 121 died of their disease, and of these 7, 5 recurred in the groin first. Surgical morbidity was improved in the short and long term, and the risk of death was not increased compared to historic controls. The higher rates of groin recurrences may have been attributable to only performing a superficial nodal dissection. Thus, inguinofemoral lymph node dissection today involves both superficial inguinal and deep femoral lymph nodes. However, the data did suggest that modified radical hemivulvectomy could be an alternative to traditional radical operation.
In the same year, GOG 88 was published evaluating the utility of groin irradiation for clinically negative lymph nodes. 58 patients with stage 1 to 2 disease were randomized to radical vulvectomy and groin dissection versus radical vulvectomy and groin irradiation. Patients with stage 1 disease were only included if they had positive LVSI and more than 5 millimeters depth of invasion. The study was closed prematurely due to increased relapses in the radiation arm. There was an 18.5% rate of groin relapse in the radiation group and none in the surgery group. PFS and OS were statistically significantly worse in the radiation group. So what's the takeaway? Nodes need to be surgically assessed if there's greater than stage 1A disease, and radiation alone won't cut it, at least with our current standard of care. More about adjuvant therapy to come.
Got it. Has anything changed since the 1990s?
Somewhat. The recommendations for lymph node evaluation based on stage remain the same, but the manner in which we do so has changed in some cases. Groin's V1 was published in 2008. This was an observational study evaluating sentinel lymph node detection with radioactive tracer and blue dye. 403 individual patients with 623 groin dissection sites in total were included if they had lesions less than 4 centimeters, depth of invasion more than 1 millimeter, and clinically negative lymph nodes. They first had a sentinel lymph node procedure, and if pathology was negative on ultrastaging, then an inguinofemoral lymph node dissection was omitted, and the patient was observed with follow-up for 2 years. If the sentinel lymph node biopsy was positive, then a full lymphadenectomy was performed. If there was greater than 1 intranodal metastasis or extranodal growth was detected, then postoperative EBRT was recommended. In the 259 patients with unifocal disease and negative sentinel lymph nodes, groin recurrence rate was 2.3%, and the 3-year survival was 97%. Morbidity was significantly improved in the short and long term. The wound breakdown was 11.7% in the sentinel lymph node group versus 34% in the full lymphadenectomy group. Cellulitis occurred in 4.5% of patients versus 21% of patients in the full lymphadenectomy group. Lymphedema was 2% versus 25% in the sentinel versus full lymphadenectomy groups. A follow-up study was published by Unk et al. In 2010 to determine the correlation between size of sentinel lymph node metastases and the chance of involvement of other non-sentinel nodes. The risk of non-sentinel node metastasis was higher when sentinel lymph nodes were detected by routine pathology versus ultrastaging. The proportion of patients with non-sentinel nodal metastases increased with the size of the sentinel node metastasis, but there wasn't an identified size cutoff to delineate an acceptably low rate of non-sentinel lymph node metastasis. Disease-specific survival for patients with sentinel lymph node mets more than 2 millimeters was poorer than for people with micrometastases at 69.5% versus 94.4%. Long-term follow-up of this study was published in 2016, which confirmed that isolated groin recurrence rate was 2.5% for sentinel lymph node negative patients and 8% for sentinel lymph node positive patients. The local recurrence rate was 25% and 36% at 5 and 10 years in the sentinel lymph node negative patients, compared to 33 and 46% in the sentinel lymph node positive patients.
GOG 173 was published in 2012 to determine the safety of sentinel lymph node biopsy to replace inguinofemoral lymph node dissection. From 1999 to 2009, 452 patients with vulvar limited squamous cell carcinoma with a depth of invasion greater than 1 millimeter, a tumor size of 2 to 6 centimeters, and clinically negative lymph nodes were enrolled. These patients underwent lymphatic mapping with isosulfan blue dye and radioactive tracer, sentinel lymph node biopsy, and an inguinofemoral lymph node dissection. Nodes were labeled as blue, hot, or both. If routine H&E was negative for metastatic disease on the first sentinel lymph node slide, IHC was performed on a second slide. 418 of the 452 had at least one sentinel lymph node identified, and 8.3% had a false negative sentinel lymph node biopsy. 23% of the sentinel lymph nodes were detected by IHC alone. The false negative predictive value of sentinel lymph nodes was 3.7%, but if this was limited to the tumors less than 4 centimeters, this rate dropped to 2%. This study established 4 centimeters as the cutoff for sentinel lymph node biopsy candidacy, given that the false negative predictive value was 2% with tumors less than 4 centimeters and 7.4% with tumors greater than 4 centimeters.
GOG 270, or Groins V2, was published in 2021. This was a prospective, single-arm, phase 2 multi-center study performed in patients with vulvar cancers less than 4 centimeters without positive lymph nodes on imaging. At the time, standard of care for patients with metastasis to the sentinel lymph node was interval lymphadenectomy, with adjuvant radiation for patients with extracapsular spread or more than one metastatic lymph node detected on said interval lymphadenectomy. The patients in the study underwent a local excision with a sentinel lymph node biopsy. If the vulvar excision was greater than 1 centimeter from the midline, they underwent a unilateral sentinel lymph node biopsy. Conversely, if it was within 1 centimeter, then a bilateral sentinel lymph node biopsy was performed. However, unilateral sentinel lymph node biopsy was allowed for patients with lesions less than 1 centimeter from the midline if the lymphoscintigram showed only unilateral drainage. Postoperatively, if the sentinel lymph node was positive, patients received EBRT with 50 gray to the lymph node bed. The primary endpoint was isolated groin recurrence rate at 24 months. Of the 1,535 enrolled patients, the rate of sentinel lymph node positivity was 21%. Of those who were positive, 50%, accounting for 150 patients, only had micrometastatic disease, defined as tumor deposits more than 0.2 millimeters to less than 2 millimeters. 121 patients underwent radiation alone, 14 received chemo, and 16 received an interval lymphadenectomy instead, while 18 had no further treatment. In those receiving radiation per protocol, 1.6% had isolated ipsilateral groin recurrences, and 1 patient had a contralateral groin recurrence. This patient had bilateral radiation as their primary treatment, so this recurrence was in a radiated field. The overall rate of groin recurrence in radiated fields was 2.4%. Among the 18 patients who received no further treatment, the ipsilateral groin recurrence rate was 12% versus 1.6% in the radiated group. There was 1 recurrence in a contralateral groin in a patient who had had an interval lymphadenectomy, but it was on the other side instead of radiation, accounting for 6%. There was no ipsilateral groin recurrences in patients with isolated tumor cells, defined as metastases less than or equal to 0.2 millimeters, when treated with radiation per study protocol.
The other 50% of patients with positive sentinel lymph nodes had macrometastatic disease, defined as tumor deposits greater than or equal to 2 millimeters, which accounted for 162 patients in total. 51 patients received radiation alone to the groins, 39 of which were bilateral. 7 of these patients also received concurrent cisplatin. Lymphadenectomy was performed in 105 patients, and 56% of these also received radiation. 6 patients received no further radiation. The overall recurrence rate was 12.2%. The rate of groin recurrence at 2 years was 22% in those who received radiation alone versus 6.9% in those who had interval lymphadenectomy with or without radiotherapy. There were no recurrences in the 7 who received chemoradiation. In the patients with negative sentinel lymph nodes, 2.7% had isolated groin recurrences. The 2-year overall survival was 95% with negative sentinel lymph nodes, 88% with micrometastases, and 69% with macrometastases. The estimated risk of disease-specific death at 2 years for patients with macrometastases was not different between those who underwent interval lymphadenectomy with or without radiation versus radiation alone, at 24.2 versus 24.4% respectively.
Sentinel lymph node biopsy with radiation led to low-grade toxicity for most. Lymphedema was more common in patients undergoing sentinel lymph node biopsy with radiation compared to those undergoing sentinel lymph node biopsy alone, and those with interval inguinofemoral lymphadenectomy had the highest rates. There are some interesting takeaways from this study. Firstly, it's interesting that a lot of patients didn't receive the treatment per the outlined protocol. The results mimic the results of GOG 88, which demonstrated that radiation alone is inferior for recurrence rate, but the overall survival might not be different. Lastly, the study demonstrated that radiation alone after positive sentinel lymph node biopsy showing micrometastases has a very low isolated groin recurrence rate. However, radiation alone after a positive sentinel lymph node biopsy with macrometastases was not sufficient, with a high recurrence rate in the absence of a full lymphadenectomy.
Interesting. What about the 7 patients with macrometastases who received chemoradiation and had no recurrences? Any thoughts on that?
Yeah, I'm glad you asked. Groins V3, or NRG GY024, is an ongoing single-arm prospective phase 2 trial investigating whether inguinofemoral lymphadenectomy can be replaced by chemoradiation in patients with early-stage disease and macrometastases. Results are expected to be presented in 2029. However, we do have some retrospective studies regarding chemoradiation. AGO CARE 1 was published by Mahner et al. In 2015. This study retrospectively included 1,249 patients with squamous cell carcinoma of the vulva who had surgical groin staging. 36% of patients had positive lymph nodes, with the majority having 1 or 2 positive nodes. The 3-year progression-free survival in the node-positive versus node-negative patients was 35.3 versus 75%, and the 3-year overall survival was 56 versus 90%, respectively. In patients with positive nodes, 55% received adjuvant therapy. Outcomes were improved if they received adjuvant treatment versus no further treatment, with a PFS of 39.6 versus 25.9 and OS of 57.7% versus 51.4%. 84% of the adjuvant treatment was radiation, and 13.5% was chemoradiation, typically with cisplatin. On subgroup analysis, the benefit was exaggerated in patients who had 2 or more positive lymph nodes. There was another study published by Gill et al. In 2015 using retrospective data from the National Cancer Database. They found that adjuvant chemotherapy, in addition to RT, was associated with an improvement in overall survival from 29.7 months with radiation alone to 44 months, with a 38% reduction in the risk of death.
So, what are the status of things in 2024? What does the NCCN have to say about chemoradiation?
The NCCN states that chemoradiation is strongly recommended for patients with 2 or more positive inguinofemoral lymph nodes or a single inguinofemoral lymph node with a macrometastasis.
What about adjuvant therapy for completely resected node-negative disease?
This is also a little murky. Some experts suggest that adjuvant radiation should be administered if the primary tumor is more than 4 centimeters, or if there are positive or close margins. Close margins are defined as less than 8 millimeters. Alternatively, it can be reasonable to re-excise or closely surveil in order to avoid the toxicities of radiation therapy. Other risk factors that can be considered in the decision is lymphovascular space invasion and the pattern of invasion with spray or diffuse pattern. Okay, Sydney, let's go over it one more time just to bring the point home. So, who is eligible for a sentinel lymph node biopsy with vulvar cancer, and who needs a full lymphadenectomy?
Patients eligible for a sentinel lymph node biopsy are those with tumors less than 4 centimeters, although some experts suggest less than 2 centimeters as the cutoff, greater than 1 millimeter depth of invasion, a unifocal lesion, those without prior vulvar surgery, and clinically negative groin nodes. Sentinel lymph node biopsies should be performed by a high volume surgeon, with greater than 10 sentinel lymph node biopsies done under supervision. As for a full inguinofemoral lymph node dissection, that should be performed if there's failure of sentinel lymph node mapping, if there's positive macrometastatic nodes greater than 2 millimeters, which was based on the groins V2 study as described, or if the patient has clinically suspicious or enlarged nodes on imaging. Last question, what if we do a unilateral node dissection and it's positive?
Good question. So, again, remember that a unilateral sentinel lymph node biopsy or inguinofemoral lymphadenectomy can be considered if the primary lesion is more than 2 centimeters from the midline. If those ipsilateral nodes are negative, the risk of positive contralateral groin nodes is 1 to 3%. If the ipsilateral nodes are positive, the risk of positive contralateral groin nodes is 15%. So the NCCN states, quote, in select cases of a single small volume unilateral positive inguinal node with a well lateralized small primary tumor and depth of invasion less than or equal to 5 millimeters, and with a clinically negative contralateral groin examination, a contralateral groin lymphadenectomy or radiation may be omitted, end quote. So this will be a risk benefit conversation to have with your patient when you come to this decision point, but most providers would probably recommend surgical evaluation of the contralateral groin.
Let's do a review of adjuvant therapy for positive nodes as well. Based on the results of the groins V2 study, if there is a single positive sentinel lymph node micrometastasis, then adjuvant EBRT with or without concurrent chemotherapy should be given. If there's a positive sentinel lymph node macrometastasis, then the preferred treatment is a complete inguinofemoral lymphadenectomy, followed by EBRT with or without concurrent chemotherapy. Alternatively, EBRT with concurrent chemotherapy without surgery can be considered. However, for patients with 2 or more positive lymph nodes or any extranodal extension on sentinel lymph node biopsy, there is a Category 1 recommendation for inguinofemoral lymphadenectomy, followed by EBRT with or without concurrent chemo. If positive nodes are detected on inguinofemoral lymphadenectomy, the recommendation is for EBRT with or without concurrent chemo.
Okay, got it. So what about if we do a vulvectomy and we have close but negative margins?
This can be a tricky question to answer because there's no universally accepted definition of close. Quoted measurements have ranged from 1 to 8 millimeters on formalin fixed tissue. Remember for the operating room, because tissue shrinks as it is preserved, aim for at least a 1 centimeter gross margin on fresh resection. Grutenhuis et al. Published a retrospective study in 2019 to give some clarity about the closeness. They found that negative margins of any distance did not impact the rate of recurrence using a cutoff of 8, 5, and 3 millimeters. On multivariate analysis, higher local recurrence was observed in patients with differentiated VIN and lichen sclerosis at the margin with a hazard ratio of 2.76, in patients with DVIN at the margin, a hazard ratio of 2.14, and in stage 2 or higher lesions with a hazard ratio of 1.6. Additionally, in the AGO CARE study, no margin level from 2 to 8 millimeters was significantly related to recurrence. Conversely, a 2016 meta-analysis had a relative risk for recurrence of 2 if the margin was less than 8 millimeters. What does the NCCN say about management of close margins?
The NCCN tells us that, quote, observation with regular close follow-up is reasonable, that re-excision should be considered for positive margins, that adjuvant RT is another alternative to re-excision, and that the survival advantage of re-excision or adjuvant vulvar radiation remains to be determined, end quote.
Has anyone looked at patient outcomes for specimens with close margins treated with adjuvant therapy?
They have retrospectively. Viswanathan et al. Published a retrospective study in 2013. Their 4-year recurrence rate for negative, close, and positive margins was 82%, 63%, and 37%, respectively. They found that margins less than 5 millimeters had the highest risk of recurrence, and a higher dose of adjuvant RT had a lower rate of recurrence. Similarly, Ignatov et al. Retrospectively evaluated the effect of adjuvant RT for patients with close or positive margins. The 5-year overall survival improved by the addition of RT at 67.6% versus 29%, with a hazard ratio of 0.36. Patients receiving adjuvant RT for close or positive margins had a similar 5-year overall survival to those with negative margins.
That's all we have for you today. Maya, you want to start us off with today's takeaways?
Of course. Vulvar cancer is rare, making up less than 1% of all cancer cases in the US. 75% of vulvar cancer cases are squamous cell. Squamous cell carcinoma can be preceded by HPV infection or can arise from differentiated VIN and lichen sclerosis, which are both HPV independent.
Survival is best predicted by stage, with a 5-year relative survival of 86% for localized disease, which decreases to 22% for distant disease. Lymph node status is the most important prognostic factor, and number of positive lymph nodes is inversely correlated with overall survival. HPV-related vulvar cancers have improved prognosis compared to HPV-independent vulvar cancers.
FIGO staging for vulvar cancer was updated in 2021. Tumor size cutoff of 2 centimeters delineates 1A from 1B disease, as can depth of invasion greater than 1 millimeter. Major changes included downstaging the presence of disease in the upper 2/3 of the vagina from stage 4 to stage 3. Measurement of depth of invasion should be done from the basement membrane of the deepest adjacent dysplastic or non-invasive ridge to the deepest point of invasion. Pathologists should document their methods for determining depth of invasion.
Treatment for early-stage vulvar cancer is primarily surgical. This includes stage 1 disease and select stage 2 disease. For stage 1A disease, a simple partial vulvectomy without lymph node evaluation can be performed. Stage 1B and select stage 2 are generally treated with radical partial vulvectomy and bilateral versus unilateral inguinofemoral lymph node evaluation, depending on the location of the primary tumor.
For vulvar cancer that is at least stage 1B, the rate of lymph node metastases is more than 8%, and lymph node status greatly affects prognosis. Typically, lymph node assessment was performed with inguinofemoral lymphadenectomy. Lesions within 2 centimeters of the midline are typically treated with a bilateral lymph node assessment. Groins V1 and GOG 173 both evaluated feasibility and efficacy of sentinel lymph node biopsy for early vulvar cancer. These studies established that in unifocal lesions less than 4 centimeters with clinically negative nodes, sentinel lymph node biopsy has a false negative rate of around 2% and a groin recurrence rate of 2 to 3% for sentinel lymph node negative patients. Groins V2 or GOG 270 demonstrated that adjuvant radiation for micrometastatic sentinel lymph nodes is an acceptable option, but in patients with macrometastases, the recurrence rate is higher with radiation compared to interval lymphadenectomy. For patients with 2 or more inguinofemoral lymph nodes, chemoradiation should be considered, as in retrospective studies, this has been associated with improved overall survival.
Tumor margins are another important factor to consider. With positive tumor margins, re-excision is generally recommended if feasible, and EBRT is recommended if surgery is not an option. Treatment of close but negative margins, meaning 1 to 8 millimeter margins depending on the study, is more controversial. Close margins have been variably associated with recurrence rate and prognosis in retrospective studies, and DVIN or lichen sclerosis at the margins seems to be worse prognostically than VIN or normal tissue. As such, close observation or EBRT is an option for management of close margins. Finally, tumor size can impact the decision to administer adjuvant EBRT, with some advocating for EBRT in tumors greater than 4 centimeters.
This has been another episode of Ready, Set, GYO, your source for all things gyno.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at Ready, Set, GYO.
To support us and our production of future episodes, check out our Patreon at Ready, Set, GYO.
This episode was recorded by Sydney Ersch and Maya Gross. Our sound editors are Brogan Brown and Kylie Knight. Our media and website manager is Sky Jacobson.
We'd like to thank Dr. Jessica Parker-Metter, faculty at the Indiana University Health, who's reviewed the content of this episode for accuracy and completeness.
Sydney and Maya signing off.